Hello, welcome to sonography-radiology training channel. This series of videos is radiologic findings in fractures and dislocations of the shoulder. This is the third video in this video series about Bankart lesion. These are my outlines in this presentation. The first one, the definition of Bankart lesion, the pathology, association with Bankart lesion, radiographic features, variants of Bankart lesions, and final teaching points. First, we can see the definition. Bankart lesions are injuries specifically at the anteroinferior aspect of the glenoid labral complex and represent a common complication of anterior shoulder dislocation. They are frequently seen in association with a hill-sachs defect. Strictly speaking, a Bankart lesion refers to an injury of the labrum and associated glenohumeral capsule and ligaments injuries. Injury to these reinforcing soft tissue structures is thought to predispose to recurrent dislocation. What is the pathology of the Bankart lesion? Bankart lesion is an MRI finding. It results from detachment of the anterior inferior labrum from underlying glenoid and is usually as a result of previous anterior shoulder dislocation. The detachment may be labral only or soft tissue Bankart, or may involve the bony margin of the glenoid, also called the bony Bankart lesion. Additionally, labral tears may also be present with bony Bankart lesion. Soft Bankart lesions are more common than bony Bankart lesions. Is there any associations with Bankart lesion? The same mechanism of compression can result in a hill-sachs defect occurs in a Bankart lesion. As I told in previous video, Bankart and hill-sachs defects are 11 times more likely to occur together than isolated injuries. What is the radiographic features of Bankart lesion? The first one in plain radiograph. In plain radiograph, it may be seen or not fracture of the anteroinferior aspect of the glenoid. Of course, if our lesion is a bony Bankart lesion. In soft Bankart lesion, of course, plain radiograph is normal. In CT scan, glenoid labrum is not commonly visualized by CT, although CT orthography may demonstrate labral avulsion. This is an axial orthography image of a 32-year-old man demonstrate capsular lesion with the detached anterior labrum, which constitute the fibrous Bankart lesion or soft Bankart lesion. Another one, like plain radiograph, it may be or not fracture at the anteroinferior aspect of the glenoid. In this coronal, oblique, and sagittal CT images, we can see the displaced fragment of the glenoid rim in the 3 to 6 o'clock position. On the coronal image also, we can see a large hill-sachs defect. What is the MRI findings of the Bankart lesion? The first one, a frank displacement or separation of the anterior glenoid labrum with or without glenoid fracture fragment. In this MR orthography, the labrum is missing on the anterior glenoid and the labral fragment is displaced anteriorly. Another MRI finding is a linear hypersignal intensity in T2 or proton density sequences through the non-displaced anteroinferior labrum, indicating a tear. As we can see in this conventional axial T2 MRI, an attenuated anteroinferior labrum, which is suggestive of a Bankart lesion. The posterior labrum appears intact and is triangular in shape. Another MRI finding, abnormally small or absent anterior labrum. This axial MRI through the humeral head shows there is a bone bruise in the humeral head, which is the biomechanical equivalent of a hill-sachs lesion, but no actual depressed fracture is present. Also, an anterior labral tear extends superiorly from the fracture. Another MRI finding is double axillary pouch sign, means a collection of fluid between a torn anteroinferior glenoid labrum and the glenoid ring, giving the appearance of a second axillary pouch. The sign is seen best with MR arthrography on the coronal view and is considered by some a very specific sign for an anterior labral tear. As we can see in this coronal MR arthrographic image, double axillary pouch sign, a contrast collection located between the glenoid ring and torn anterior labrum. Now, what is the variants of Bankart lesion? The first one is Pertus lesion of the shoulder. The second, anterior labral ligamentous periosteal sleeve avulsion or alepsa, and glonolabral articular disruption or GLAD lesion. The first one, Pertus lesion. A Pertus lesion is a labral ligamentous avulsion like a Bankart, but with a medially stripped intact periosteum. This image shows a Bankart lesion with periosteal disruption and detachment of the anteroinferior labral fragment. And this image is a Pertus lesion which shows minimal periosteal stripping with non-displaced detachment of the labral fragment. There is only minimal displacement of the torn anterior labrum, and hence the lesions are difficult to diagnose on routine MRI or MR arthrography. MR arthrography with arm in abduction and external rotation stretches the anteroinferior joint capsule and also inferior glenohumeral ligament and helps in better delineation of the lesion. This is an example of Pertus lesion. We can see in this T1 fat saturated axial MRA image, and this is T1 fat saturated oblique axial MRA image, which both of them were taken in abduction and external rotation position. They show intercalation of the intra-articular contrast beneath the anterior labrum with an intact periosteum. This suggests a diagnosis of a Pertus lesion. This T1 fat saturated oblique sagittal MRA image shows the extent of the lesion. It's important to detect this lesion on MRA as it can be missed on arthroscopy because of the minimal displacement. Another variant is anterior labral ligamentous periosteal sleeve avulsion or alepsa lesion. In alepsa lesion, we can see periosteal stripping with medialization of the labral fragment into the periosteal sleeve. The anterior labrum is absent on the glenoid ring, but mobilized labrum remains attached to the glenoid periosteum. This is an example of acute alepsa lesion. We can see axial in neutral position and axial in abduction and external rotation position MR arthrogram, which shows contrast material entering cleft between the anteroinferior glenoid and labrum. The labral tissue is detached in situ with the periosteal attachment stripped but not torn. Identification of a cleft in the neutral position allows an acute alepsa lesion to be distinguished from a Pertus lesion. The abduction and external rotation image shows the degree of periosteal stripping. This is an example of chronic ellipsal lesion. This axial non-fat saturated MR orthogram shows an anteroinferior labral fragment displaced medially and inferiorly by a mantle of a surrounding fibrous scar tissue. Another one we can see here, a stripped periosteum which is not torn. The last variant is glenoid articular disruption. It represents a partial tear of the anteroinferior labrum with adjacent cartilage damage. This is an example of Bankart lesion. In this successive axial MR orthograms show a tear of the anteroinferior labrum with an associated defect in the adjacent cartilage, suggestive of a Bankart lesion. Now, please pay attention to these final teaching points. The double axillary patch sign is seen best with MR orthography on the coronal view and is considered by some a very specific sign for an anterior labral tear and diagnosing Bankart lesion. MRA with arm in abduction and external rotation position is very important for diagnosing pertus lesion, and it is important to detect these on MRA as it can be missed on arthroscopy because of the minimal displacement. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.